Good afternoon, everyone. Welcome to our program, The Connection Between Viral Hepatitis and Liver Cancer. My name is Ivory Allison, and I am the National Senior Director of Community Impact for the American Liver Foundation. ALF's mission is to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. As part of our commitment to the liver community, ALF offers a range of educational programs and resources for patients, caregivers, and providers. Today's program will be recorded and shared on our YouTube channel. To ask a question or for general comments, please use the chat and question button. Our new resource is at the American Liver Foundation's Patient Registry, the first ever patient registry for all liver diseases. Our goal is to help researchers better understand liver diseases and learn how these diseases and current treatments impact patients' lives. The registry is open to individuals 18 years and older in the United States with any type of liver disease at any stage, including transplant recipients. Participation is easy and includes a user-friendly online survey that will only take 15 to 30 minutes of your time. You can use this QR code or link to learn more to participate in the registry. Don't wait. Share your experience to help change the future of liver disease. If you're looking for more information after the webinar, we encourage you to visit liverfoundation.org. There, you can also find details about our virtual and online support groups, as well as opportunities to get involved as an advocate. We also invite you to connect with us on social media. You can find us on all the channels: Facebook, Instagram, LinkedIn, X, and YouTube. We look forward to staying in touch. I'd like to now introduce Dr. Emmanuel Thomas, the Associate Professor at the University of Miami School of Medicine, Florida, and the American Liver Foundation Board Chair, who will moderate the Q&A this afternoon, but will introduce our speakers and officially start the program. Dr. Thomas.
Thank you, Ivory, for that kind introduction. Education about viral hepatitis and its links to liver cancer is crucial for several reasons. It empowers individuals to take preventative measures, reduce stigma, and it helps people access timely testing and treatment, ultimately improving public health outcomes. The World Health Organization guidelines for hepatitis elimination focus on reducing the incidence of hepatitis B and hepatitis C by 90% and mortality by 65% by 2030. This will be achieved through a combination of preventative measures, testing, and treatment interventions. We hope the efforts of the American Liver Foundation will contribute to achieving these goals. Our featured speakers today are Dr. Josiah McCain, transplant hepatologist and clinical assistant professor at the University of Florida, Division of Gastroenterology, Hepatology, and Nutrition. Beatrice Zovich, public health program manager for the Hepatitis B Foundation, where she has worked for 5 years. I'm now going to turn the program over to our speakers, beginning with Dr. McCain to get us started today. Dr. McCain, thank you.
Thank you, Dr. Thomas. Thank you, Ivory, and thank you to the American Liver Foundation for letting me speak today. I am going to talk about this topic, the link between viral hepatitis and liver cancer. And my approach to this talk is going to be very informational. I think that if we look at some of the basic concepts behind what cancer is, how cancer behaves, how the liver behaves, and what viral hepatitis is and how it impacts the liver, then the link between viral hepatitis and liver cancer can be something that we can all understand. And then we'll talk about what do we do about the link between viral hepatitis in terms of screening and in terms of management. So if you can go to the next slide for me. So let's start very basic, zoomed out view of what is cancer. And these quotes, these points here I took from a book. If you have interest in cancer in general, Siddhartha Mukherjee's book, The Emperor of All Maladies, great book, very readable. I recommend it. But cancer is in general the uncontrolled growth of a single cell. That definition implies that there is a controlled growth of a single cell in normal cellular development. All our bodies obviously are made up of cells, and those cells live, they regenerate, They proliferate, they divide, and they die when they're injured or as some kind of programmed cell death. They're most vulnerable to DNA damage. Now, our bodies have ways of pruning this DNA damage and getting rid of cells that show these kinds of mutations. But every once in a while, a mutation occurs that impedes the body's ability to do that. For example, a mutation in the system that programs cell death would mean that a cell wouldn't die and become immortal. And those cells can grow in a disordered fashion, and they can proliferate. And that is what a tumor is. Cancer is not one illness, it is many illnesses. We talk about liver cancer, or colon cancer, or lung cancer, or brain cancer. Cancer is generally named for the tissue in which it starts. So what type of cell went wrong? Was it a liver cell? Was it a bone cell? Was it a skin cell? But it doesn't always stay in that position. For example, metastatic cancer means cancer that has gotten out of the original tissue. Colon cancer can go to the liver. It's still colon cancer, but it's in the liver now. Liver cancer can go to the lung. It's still liver cancer, but it's in the lung now. It's not one illness. It's many different types of illnesses, and they all tend to behave certain ways because all of those cells all those cancers come from different cells. But that's what cancer is. It's also important to know that it is the fastest growing disease on the planet, and I'm sure that's not a surprise to anyone. Most of us will either be impacted personally by cancer, or we will have loved ones who will be impacted personally by cancer in our lifetime. So a very important concept to understand, a very important disease to be familiar with. Next slide, please. So let's talk specifically about what liver cancer is. When we talk about liver cancer, liver cancer can refer to a handful of different cancers, but in general, when we say liver cancer, we're talking about hepatocellular carcinoma. That's a cancer that grows in the hepatocyte. The hepatocyte is the functional cell of the liver. It's a leading cause of cancer deaths worldwide, and it's important for us to understand exactly why it's a problem. Obviously, all cancer is a problem, but specifically, what is it about liver cancer? Hepatocellular carcinoma occurs when there's this uncontrolled growth of liver cells. Liver cells, a normal liver cell, what a liver cell does is it processes things that basically go through your body. One of the jobs that the liver does, among many, is that it processes everything that goes into our mouth. So food, water, medications, alcohol, anything that would be absorbed by the GI tract is absorbed in the gut and then processed through the blood into the liver. And the liver is going to make decisions about what is toxic and what is not, what is helpful and what is not. And it will break down toxic things so that they either become not toxic or so that they can be flushed out of the system through the urine or the stool. So the liver kind of acts as an interface between us and the rest of the world. Because of that, the liver does go through a periodic injury, and that's normal. If you drink alcohol, liver cells will die. If you take some herbal medicine that might have some liver toxic effects or some drug that has some liver toxic effect, hepatocytes will be injured, and that's normal. Because of that, the liver has the ability to regenerate. In fact, if you took a liver, and this happens to patients sometimes who have, say, liver cancer or some problem with the liver, and you cut off a lobe of the liver that's left over, the piece that is left over would grow to recompensate for that area that's gone, up to about 80% of the original volume and maintain 100% of the liver function. So the liver can regenerate. It's built that way. It's supposed to regenerate because it's built to take injury. It's built to metabolize those toxins, those things that come from the environment. What that means practically is that there is a lot of cell turnover in the liver. Anywhere there's a lot of cell turnover, anywhere that there's a lot of cell death and a lot of cell growth, cell proliferation, you're going to increase the chances that DNA damage can happen, that mutations can happen, and thereby that cancer could occur. For that reason, the liver's full of lymphatic cells, and those lymphatic cells are supposed to prune bad cells when they do occur. They're supposed to get rid of things that could potentially become tumors. But every once in a while, cancers can grow unchecked, and they become hepatocellular carcinoma. Fortunately, it is an easy cancer to detect and diagnose. We can diagnose liver cancer simply with imaging. So ultrasound MRI, CT, those things can pick up liver cancer. You don't need necessarily a biopsy to prove it. Hepatocellular carcinoma grows in a very well understood and predictable way. And it's easy for radiologists on ultrasounds or CTs or MRIs to pick up those findings and diagnose cancer. And catching it early is the real key, because if we do catch it early, there are good treatment options. Next slide, please. So now we'll talk about what is viral hepatitis. Viral hepatitis refers to a group of viruses, none of which are really related. We name them by what they do, not by what they are. And what they do is they damage the liver. Hepat means liver, itis means inflammation. So these are viruses that cause inflammation in the liver, and we name them with letters: hepatitis A, hepatitis B, hepatitis C, hepatitis D. Today, we're going to focus mainly on hepatitis B and a little on hepatitis C, because those two viruses have the potential to set up a chronic infection in the liver. In other words, it's not like a flu or a COVID that you get and you get over. This is a virus that can live in the liver and cause damage over time. The good news about hepatitis C is it's curable. It's been curable since about, I think, 2014 or so, when the direct acting antiviral agents against hepatitis C were introduced. Prior to, say, 10 years ago or so, hepatitis C was a major problem. In fact, it was the #1 indication for liver transplant in the United States, because it would last for patients' entire lives, damaging the liver the entire time. The treatments for it were not good. It was treatable, but mostly not curable for most patients. And most patients developed end-stage liver disease or cirrhosis from hepatitis C. Now we can cure it. And since we can cure it, the prevalence of hepatitis C is lower than it used to be. And so the implications from that disease are not as important or as impactful as they used to be. It still is a problem. We still find it. We still are able to cure it. We still see people get cirrhosis and liver cancer from hepatitis C. Hepatitis B, not curable. Hepatitis B is what hepatitis C was 14 years ago. It's treatable, but not curable. Patients with hepatitis B, chronic hepatitis B, need to remain on medications to fight hepatitis B for the rest of their lives. Despite that, even on good treatment, if you biopsy the liver of a patient with hepatitis B, you will see that there is some degree of inflammation and liver damage going on, even those who are getting treatment. It's much less, obviously, in those who are not treated. But hepatitis B and hepatitis C both represent constant injury and injury to liver cells as long as the patient is infected. They are both risk factors for cirrhosis, and cirrhosis simply refers to the concept that once a liver is injured enough, it begins to scar. And once that scar is the dominant tissue in the liver, in other words, you've basically got more scar than you do normal liver tissue, and you've overcome the ability of the liver to do that regeneration that it's supposed to do, that's cirrhosis. And they're both independent risk factors for liver cancer, which is why we're talking about them today. Next slide, please. So this is the distribution of chronic hepatitis B worldwide from 2006. This is from the CDC. And I just want to point this out quickly because it is going to impact who we screen for liver cancer and why. The dark blue countries are those in where hepatitis B is most prevalent. And you'll notice that what we call sub-Saharan Africa or Central Africa and Southern Africa and Asia, especially Southeast Asia, are dominant. And then some areas in Latin America, South America. These are areas we think of as endemic hepatitis B countries. That is, that patients who live there or were born there are at higher risk for developing chronic hepatitis B. Next slide, please. Okay, so if we understand those things that we've already talked about, what does that mean, really? If we put together what cancer is and how it behaves, we put together our understanding of the liver and liver cancer, and that cell turnover that goes on in the liver can increase the risk of developing cancer. And then we recognize that chronic viral hepatitis represents a constant threat to the hepatocyte, a constant threat of cell death and cell turnover and proliferation and direct damage to the DNA of the cells. We can understand that that would imply that chronic hepatitis B and chronic hepatitis C increase the risk for liver cancer. Next slide, please. So, who needs screening? Well, first of all, we screen all patients with cirrhosis, regardless of whether or not they have hepatitis B or hepatitis C. All patients with cirrhosis need screening for hepatocellular carcinoma, for liver cancer. Patients who have hepatitis C and who have stage 3 fibrosis also need liver screening. So what that means is that fibrosis we grade from 0 to 4. 4 is a cirrhosis. We call 4 cirrhosis. 0 is no fibrosis. When they get to 3, when a patient gets to stage 3 fibrosis with hepatitis C, we consider that a risk for hepatocellular carcinoma, and those patients need screening. Chronic hepatitis B tends to be a little bit higher risk for liver cancer, and there's a few more patients that would be screened with hepatitis B. Of course, all those with hepatitis B and cirrhosis, but also men from endemic countries. And in endemic countries, we're talking about those countries that we saw on the chart there, who are 40 years of age or older. Women from endemic countries who are 50 years of age or older. In the past 10 years, I want to say, maybe the past 8 years, I can't recall, but we have added this other category, persons from Africa, because the incidence of hepatitis B and particularly hepatocellular carcinoma is higher in those patients. Patients from Africa who are over 30 years of age need screening. And then, of course, anybody, well, not of course, but anybody with chronic hepatitis B whose family members also had hepatocellular carcinoma. So that would be, usually we're talking about first-degree family members, so parents, brothers, and sisters. These are the patients who would need screening, and screening is every 6 months. Next slide, please. How do we screen for liver cancer? As we mentioned before, an image of the liver, usually an ultrasound. Ultrasound implies no radiation. There's no radiation damage from ultrasound. It's usually comfortable for the patient for the most part, and it's cheap. CTs and MRIs can do this too. They're more expensive, and they do carry radiation. And if you're going to be getting a test every 6 months, it's better off that we do something without a radiation risk. And we couple that usually with a blood marker called AFP, stands for alpha-fetoprotein. Alpha-fetoprotein is made by the liver cells. And in liver cancer, it's often elevated in those patients. Not always, but it's often elevated. And so if it's elevated in the patient, it makes us more suspicious for liver cancer. But the patients that we talked about on the last slide should get an ultrasound or some kind of image of the liver with an AFP every 6 months. Next slide. So, in summary, we understand what cancer is. It's uncontrolled growth of cells. Liver cancer, or hepatocellular carcinoma, is a major cause of cancer deaths worldwide. Hepatitis B and hepatitis C virus can induce chronic liver damage, increasing the risk for liver cancer. And hepatitis B and hepatitis C are independent risk factors for liver cancer, as well as cirrhosis. Screening for cancer is easy, and it's also effective. And if we catch these cancers early with every 6 month screening, patients are available for surgery, they're available for radiation, for chemotherapies, and even transplant, if needed, can cure cancer. Next slide. Thanks very much. That's my last slide, apparently.
All right. Thank you so much that was a great comprehensive presentation, and thank you to the American Liver Foundation for having me. My name is Beatrice. As was mentioned, I work at the Hepatitis B Foundation. We do a lot of work about highlighting the connection between hepatitis B and liver cancer and trying to raise awareness about this among particularly communities that are heavily impacted and at high risk for developing liver cancer. So I will just provide a brief overview of some of these programs today. Next slide, please. Thank you. So the first, our main program that I'll highlight is called Liver Cancer Connect, which just works to raise awareness of hepatocellular carcinoma or primary liver cancer from all etiologies. So the biggest, hepatitis B contributes to the majority of HCC cases, but there's also, as was mentioned, can come from hepatitis C, fatty liver disease, a variety of other etiologies. So we use this program to really try to promote diagnosis, screening, research, and treatment, as well as to highlight different avenues of support for those who are diagnosed with HCC and their loved ones. So we do this through maintaining an active website and social media channels as well, which I can put in the chat in just a few minutes. And also through various activities like webinars, blog posts, and podcasts, as you can see here on the slide. Next slide, please. Thank you. So one of our more recent programs that we've done over the past couple of years is an ongoing campaign called Learn the Link, which is designed to specifically highlight the connection between hepatitis B and liver cancer, and again, make communities that are heavily impacted aware of this connection to encourage first screening for hepatitis B, but then also ultimately surveillance, regular surveillance for liver cancer for those who are positive. So this was a project that was developed to better understand existing knowledge and perceptions about hepatitis B and its relationship with liver cancer in high-risk communities, and to use the findings to develop and employ effective communication strategies that raise awareness and dispel myths. Some of the common myths are that, people who have liver cancer, any type of liver disease, must be heavy drinkers and have used a lot of alcohol. That's a very common thought among multiple different groups. So there's others as well, but just trying to bring accurate information to raise awareness. So in order to do this, we convened, this was in 2021, we convened 15 focus groups and 2 key informant interviews with community members and leaders and public health experts from around the United States. You can see the communities that were included on the slide. They're primarily immigrant communities, since the majority of the burden of hepatitis B in the United States is found in communities that have immigrated here from countries that have where hepatitis B is endemic. And so we also had an advisory committee of 14 community and public health leaders who helped to shape the project as well, including interview guides and focus group guides. Next slide, please. So we've now been able to launch the campaign. So based on the information that we collected through the focus groups and interviews, we created a variety of printed materials and social media assets that are available for 12 different communities in total. I'll again put the website in the chat momentarily. We have all materials are available in English, and now we're working on translations as well. So we currently have translations available in Cantonese, Mandarin, Haitian, Creole, and Somali, and we're working on the rest. We've also done a radio PSA ad in Chukis and a local radio station in Hawaii. And we have conducted community leader trainings for the Cantonese and Vietnamese communities, and hope to do so as well for Haitian, Creole, and West African communities in the near future. And we've also had videos created in Mandarin. So we're continuing to work on creating more assets and that were requested by different communities, including videos and other multimedia materials. Next slide, please. Thank you. So finally, I just want to highlight an event that we have coming up. This is a liver cancer patient-focused event called Liver Cancer Working Together to Tell a New Story. The purpose of the conference is to create a space in which people with both direct and indirect experience of liver cancer, as well as those with risk factors, can learn more about the disease itself, including things like basic epidemiology, the importance of early detection and routine surveillance, some of the challenges and opportunities for improvement in this area, experience with navigating the HCC cascade of care, so the whole process from diagnosis to management and what that looks like, research updates and strategies for addressing HCC at the community level from a variety of perspectives, and how best to work collaboratively to improve HCC outcomes. So we'll provide a platform for people with lived experience, healthcare providers, and researchers to engage in meaningful conversation about HCC. So I have the links also for the agenda and the registration, which I'll put in the chat as well. But I think that concludes my presentation. So thank you so much.
Okay, thank you, Beatrice. We really appreciate your contribution to this webinar and updating us on the great work that the Hepatitis B Foundation does. So let's start the Q&A. And my first question I'll send to Dr. McCain. And the question really addresses how to interpret hepatitis C and hepatitis B test results. We know this can be complicated, so I'd like you to start with hepatitis C. That may be more simple, and then transition to hepatitis B. Thank you.
Yeah, it is complicated. It's complicated enough that it's board questions for us. So I'll start with hepatitis C, which as Dr. Thomas mentioned, is a little easier. So when we're testing for hepatitis, we're testing for a couple of different things. In general, there's a test for the virus, and that is called PCR, polymerase chain reaction. It's looking for the actual DNA or RNA of the virus. And then we're checking for your body's response to the virus, antibodies, basically. In hepatitis C, we tend to check for the antibody first. That's the screening test. So we check the blood of a patient. If they have the hepatitis C antibody, then we know they've been exposed to it at some point. The next step is then to check for the virus itself, and we'll check for the RNA in the blood. If the patient's hepatitis C antibody is negative, then we don't check for the virus because your antibody would need to be positive for the patient to be infected. Hepatitis B is a little bit more complicated because we care about what stage the viral replication is, and viral replication hepatitis B is kind of complicated, but we check for immunity by looking for something called hepatitis B surface antibody. And if your hepatitis B surface antibody is positive, that means you've either been exposed to hepatitis B or you've been vaccinated. If you want to determine which that is, you then check for the core antibody. So there's two antibodies here. The hepatitis B core antibody signals that you've actually formed immunity to the virus itself. That's why it's called core. It's the core of the virus, not an immunization or a vaccine. So if the next things that we test for is the signs of the virus itself. So we test them in a couple of ways. Hepatitis B surface antigen, not antibody, is a sign of active hepatitis B in the blood. And then if that's positive, we want to know the DNA level too, because the DNA level will help us decide whether we treat someone for hepatitis B, because not everyone with hepatitis B in the blood actually gets treated for it. It's only those who have obvious signs of liver injury and have hepatitis B DNA up to certain levels. So we'll check the DNA of the hepatitis to see how high it is. There are a few other things that we check, hepatitis B, E antigen and antibody, but those things that I mentioned, those are the basics.
Fantastic. Thank you for those great answers. And then a related question is the antibody levels and how antibody levels can be positive in, let's say, for hepatitis C in patients that have been cured of the virus. Can you address that? Because that can be confusing sometimes.
Perfect. Yes, that's a great question. And I have seen patients come to me at times for a consult for hepatitis C when they don't actually have hepatitis C. What they have is a positive antibody. So checking for the antibody is, as I said, an indication that you have been exposed at some point to hepatitis C. We don't have a vaccine for hepatitis C like we have to hepatitis B, because if I check for hepatitis B antibodies, many people in the US would have them because they've been vaccinated. Hepatitis C indicates that someone's been exposed. Many people who are exposed to hepatitis C do not develop the infection of the virus. It just means that they've been exposed to it and their immune system has reacted to it, and they will always be positive for hepatitis C. That goes also true for those patients that you mentioned, Dr. Thomas, patients who had hepatitis C and were treated for it. If you had hepatitis C infection and you were treated for it, and your hepatitis C RNA is undetectable, it's gone, your hepatitis C antibody will be positive probably for the rest of your life. Rarely people will lose the antibody, but most of the time it will always be positive. And that doesn't mean that the person is infected. It just means that they had it at one point or they were exposed to it at one point.
All right. Thank you, Dr. McCain, for clarifying that. And we acknowledge that these tests that the doctors perform can be complex, but we want to make sure that everyone has support to really understand their lab values. So thank you, Dr. McCain. Beatrice, so thank you very much for the content that you presented. So you've developed language-specific content for vulnerable populations. And I wanted to know, how do you get that out to the community? So in South Florida, where I'm from, we have a large Haitian population. How can we, help these populations that may have more chance to have liver cancer because of their exposure to hepatitis B?
Yeah, so we find that primarily working with community leaders of community-based organizations is really effective. So we actually, one of the focus groups that we did was with the Haitian Creole community in South Florida. And we worked with a hepatologist at the University of Miami to recruit folks to participate. And now we're working on gathering community leaders to do a kind of train the trainer model to get people equipped with accurate information about hepatitis B and liver cancer so that they in turn will be able to bring it to community events, faith-based settings, other places where community members feel comfortable, and we'll be able to learn about it in turn. We also have the materials, the printed assets available to be printed and mailed to anyone for whom they could be useful. So yeah, really trying to organically reach community leaders directly and faith leaders as well, we find is most effective.
Thank you, Beatrice. And then one other related question. So with hepatitis B and liver cancer, we've talked about family risk and, understanding if people in your family have had exposure to hepatitis B or they've had to deal with liver cancer. Do you have any suggestions from your work groups that you learned on how people can talk about this within their family to understand their risk, and especially in these endemic populations where there could be a higher prevalence of these diseases?
Yeah, definitely. We did find, in almost all of these communities, family is a very key importance. So really kind of emphasizing that getting tested and, learning your status can be really beneficial, not just for your own health, but for your family's health, and working to protect the larger community. So yeah, we find that to be a really crucial message. And also, there's so much, particularly around hepatitis B, there's a great deal of stigma. So that can also, largely impede testing. There's a lot of fear of social isolation and, being cut off from the community. So that's why really kind of spreading accurate information, dispelling myths, and, working to really also drive home the message that hepatitis B in particular can really affect anybody as well. And that it's not like a punishment or anything like that, to really try to normalize the conversation around it is really key as well, and just get more people talking about it to kind of shed light on it, so it's not so psychologically damaging as well. So.
Thank you, Beatrice, so much. I mean, you addressed the issue of stigma, and Hepatitis B Foundation is definitely tackling the challenge of hepatitis B stigma. The American Liver Foundation, we acknowledge that there's stigma for liver disease in general, and we want to empower patients to talk about liver disease and understand that they're not alone, to really try to decrease that stigma and help patients that are impacted to really seek care and get appropriate help. So thank you for mentioning stigma. It's something that we acknowledge. So I'm going to switch it back to Dr. McCain. Dr. McCain, this is a kind of a complicated question, so I'm going to ask you to do your best. And it may touch on the topic of hepatitis B reactivation. So the question specifically is, my dad has HCC and also hepatitis B. Some doctors are suggesting immunotherapy that includes atezolizumab, bevacizumab combination, but another doctor is saying that this can't be used because he has hepatitis B. Any thoughts on that? This is complicated. And again, I think it's touching to the possibility of reactivation, and does it play a role here?
Yeah, it is complicated, and it depends on your father's status currently, whether he's currently has uncontrolled hepatitis B, or he's been exposed in the past and had hepatitis B, and we're worried about it reactivating. But we do know that certain medications, particularly medications that you might consider chemotherapies or immune suppressive medications, or what we call B-cell depleting units, impede your body's ability to keep hepatitis B at bay. So once a patient had been exposed to hepatitis B, even if they don't develop the infection, they tend to harbor the DNA from the virus in the liver for the rest of their life. And there is some risk if that patient develops cancer and needs to be on chemotherapy, or if the patient has an autoimmune disease and needs to be on some kind of biologic therapy, that you could reactivate that hepatitis B at some point. You could wake it up if it's not already awake. Bevacizumab, usually not. But again, I don't want to comment directly on your dad. I think it depends. Most oncologists who would prescribe these medications are well aware of the hepatitis B implications for them. So I think consultation with an oncologist and a hepatologist would kind of help make those decisions. But most doctors are very well versed in the fact that these certain medications for treatment of cancers can awaken hepatitis B or cause it to reactivate and have to be done carefully. And the agents have to be chosen appropriately. So he may not be a candidate for this agent, but might be a candidate for another.
Thank you, Dr. McCain. We appreciate that. These are very complex questions, and we hope that patients dealing with these will have multiple sources to help them get through tackling these questions. The next question to Dr. McCain. I think this touches on steatotic liver disease. And so the specific question is, a parent of mine developed cancer of the liver, and his mother did the same. Both were in their 70s and 80s. My father was pre-diabetic and took medicine for years. And my grandmother, his mother, was diabetic, both with liver cancer. Wanted to ask specifically, is there an increased risk with diabetes for liver cancer, and your thoughts on that?
That's a great question, because fatty liver disease, metabolic associated steatotic liver disease, or what we call MASLD, we used to call it MASH, or we used to call it NASH, sorry, is a huge problem in the US. We think that maybe 30% of patients have it, and it sounds like that's what your parent had or has. And that is a risk factor for liver cancer when it develops into cirrhosis. Usually people with just fatty liver disease do not develop liver cancer. And it's not clear that there's a strong inheritance pattern of liver cancer either. We mentioned that patients with viral hepatitis B tend to, and family members with liver cancer need screening. But in general, patients who just had a family member with liver cancer don't need to be screened necessarily. Now, that's for hepatocellular carcinoma specifically. I did mention there are a handful of other liver cancers that are rarer, that don't fall quite into the same category, but hepatocellular carcinoma we understand quite well, and it is the most common liver cancer, highly associated with hepatitis B, and can occur with patients who develop cirrhosis from metabolic associated steatotic liver disease. So in general, if you're asking if patients with fatty liver disease and liver cancer convey a risk to their relatives, only in so much as those patients also develop fatty liver disease and cirrhosis. It's really cirrhosis that's the risk factor.
So thank you for that, Dr. McCain. We appreciate that distinction that fatty liver disease can be a precursor for liver cancer, and that's what individuals need to find out if they have a history of diabetes, is their fatty liver disease status. Thank you very much. Back to Beatrice. So we've already talked a little bit about treatment for liver cancer, and it's complex. It can involve liver transplant, liver resection, treatment with multiple medications. How is the Hepatitis B Foundation helping with patients to navigate the complexities in the treatment of liver cancer as part of its Liver Cancer Connect program?
Yeah, so we try to provide support as much as possible. So we have a physician directory if people need assistance with locating a doctor in their area. We have connections to a variety of different support groups as well that are both online and in person. And we're always happy to, work directly with people. We have a network also of hepatologists and gastroenterologists around the country, so we can connect people through that with resources in their area that can be helpful, to link them to care. We also have a variety of resources from, multiple different national networks and associations on the website that have, full information about liver cancer. And we try to cover the entire process too. So ranging from symptoms that, may or may not appear, what happens after an initial diagnosis, the various options for treatment, whether that be, ablation, resection, other types of therapeutics, as you mentioned, health insurance as well, and kind of, how to navigate that, because that's, of course, part of the process as well. So we have multiple pages covering all of these different topics, and there's also a contact us page as well. So if you have any questions or need direct support in your area, you can always feel free to reach out.
Thank you, Beatrice. And the treatment of liver cancer is evolving, and we've seen really significant improvements in treatment from years past with new drugs and new approaches. So we're very thankful for the efforts of the community to develop these therapies, and they continue to evolve and continue to improve. So back to Dr. McCain. The question is, can you explain the effects of liver cancer and causing its effects on different body organs? I specifically maybe just talk about symptoms of liver cancer and things that people should be looking out for in case they're worried about it.
Sure. Yeah. One of the scary things about cancer is that it can show up without symptoms. And that's certainly true for liver cancer. But symptoms of liver cancer, people usually think, well, I had a pain in my liver, so I'm worried about cancer. It really doesn't cause pain much. In fact, there's not a lot of pain receptors in the liver, the tissue around the liver, the gallbladder, things like that. What really are symptoms of liver disease are the same symptoms of liver cancer, which would be things like jaundice. If you get jaundice, you need to be checked out. You need to get blood work, yellowing of your eyes. And a lot of times, by the way, it's the people around you that may notice this before you do, because you may be looking at yourself in the mirror every day. Someone will notice, hey, you look a little more yellow. But in general, the symptoms of liver cancer or onset of liver cancer are similar to the symptoms of chronic liver disease, things like swelling in the abdomen, brain fog or confusion, and jaundice can all be things that can precipitate liver cancer. Right upper quadrant pain along with fever. So pain where the gallbladder would sit along with fever, that's a concern, especially if it's associated with jaundice, but it doesn't necessarily mean liver cancer. There's a lot of things that overlap with those symptoms, and they could be, but definitely would indicate that you need to be checked out by a doctor.
So thank you, Dr. McCain. Related to that, so patients have symptoms and they need to go get checked out by a hepatologist for what those symptoms are. So one of the things that gets addressed is fibrosis. So the specific question is, what is the best test to check if one has fibrosis? FibroScan, FIB4, or biopsy?
No, that's an informed question. Yeah, so that's a good question. So it depends on what you're looking for. If you're looking for fibrosis, and fibrosis is just scarring in the liver, it's actually not easy to tell. FibroScan is a great test. FibroScan, if you don't know what it is, it's kind of like an ultrasound in the fact that they put a probe on your skin, but the probe vibrates. And the concept is that it will shake the liver. And depending on how shakeable the liver is, the machine can tell you whether it's soft or hard. And harder things tend to be fibrotic. So FibroScan is a good test to tell whether the liver is hard. And if it's hard, it might be fibrotic. It's not very specific, though. In other words, you can have a hard liver because it's congested. You could have a hard liver because it's inflamed from something like viral hepatitis. You could also, in patients who are very large, have difficulty getting that test, and it might be abnormal because the patient is obese or has some scar tissue in the way. So it's not the best test, but it's a good start. FIB4 is specifically a test for cirrhosis, and cirrhosis, as we mentioned before, is fibrosis when it gets to its end stage. FIB4 is a good test for cirrhosis. It's got good sensitivity and specificity. In other words, it's pretty accurate. So FIB4 is a good place to start, but to be honest with you, cirrhosis is not the easiest thing to diagnose. It has certain imaging characteristics on CT. It has certain lab values like low platelets, but The gold standard for testing for fibrosis and cirrhosis is biopsy. And that doesn't mean that everybody needs to have a biopsy if there's concern for fibrosis or cirrhosis. For the most part, a FibroScan is probably okay as long as it's, grade 1 or grade 2 fibrosis. When we're getting into advanced fibrosis or concerns about cirrhosis, you need to see a hepatologist, because that takes a lot of data from this test and that test and the other test to put them together to say, not only do you have fibrosis or cirrhosis, but where did it come from? What's the risk, and what do we need to do about it?
Thank you for explaining that. I think a lot of patients with liver disease are dealing with fibrosis assessments, so I really appreciate that clarification. Beatrice, wanted to talk about vaccination. So for Hep C, we don't have a vaccine yet, but thankfully for hepatitis B, we do have a vaccine. And patients with liver disease, especially that don't have hepatitis B, need to be vaccinated so that they don't get another liver disease on top of a pre-existing liver disease. Can you talk about Hepatitis B's Foundation's efforts in supporting vaccination?
Yeah, absolutely. We heavily promote the hepatitis B vaccine. So recently, actually, in 2023, the CDC has now recommended hepatitis B vaccination for all infants, children under the age of 18, adults aged 19 to 59, and then adults over age 60 with risk factors. So essentially everybody should receive the hepatitis B vaccine. It's a highly effective vaccine. It's been given over 1 billion times. It's very, very safe. And it is really one of the it is essentially an anti-cancer vaccine because it does effectively prevent, one of the leading causes of primary liver cancer. I think over 90% of people respond to the vaccine and are then protected for life. It's usually a 3-dose vaccine, meaning you receive 1 dose, then a month later, 2nd dose, and 6 months later, the 3rd. But there's also a 2-dose version now, which is great because it's 1 less appointment. So you just get 1 dose and then a month later, the 2nd dose. So we very much, recommend this. There's also a resolution that's been introduced in Congress designating April 30th as National Adult Hepatitis B Vaccine Day every year. So heavily promote and encourage everybody to get the hepatitis B vaccine.
All right, thank you so much. The American Liver Foundation also supports increased vaccination efforts for hepatitis B, very important, both in the US and globally. Dr. McCain, now this is a complex area, but could you just give the group an overview on the treatment approaches for liver cancer? I know it can be complicated depending on both the stage of liver disease and the extent of cancer, but Dr. McCain, if you could do your best and give an overview for the patients, that'd be great.
Yeah, it does become complicated, and obviously it's very patient specific, but in general, the first thing you want to know is, does the patient have cirrhosis, chronic liver disease? If it's hepatitis B related, or if it's incidental liver cancer, then usually the best treatment, if the patient's not cirrhotic, patient does not have cirrhosis, then usually the best treatment is surgery, as long as the tumor is confined to an area of the liver that can be resected. That's the best treatment. That might be followed by some local radiation. It might be followed by some immunotherapy or some chemotherapies. But in general, cutting it out is the first line. We can't always do that. Many patients with liver cancer, in fact, most patients with liver cancer have cirrhosis. Some patients with cirrhosis are candidates for surgery, but some are not. Patients with decompensated cirrhosis, so patients who have developed ascites or varices, whose bilirubins are very high, really it depends on the extent of the cancer. If the cancer is localized, small, it's not found outside the liver transplant is probably the best option for those patients. If the cancer is beyond that, it's beyond the ability of us to transplant or to surgically resect it, immunotherapy is a pretty good option. Immunotherapies are things that, in general, they are medicines that tune your own immune system to fight cancer. In fact, your immune system is your primary defense against cancer. And immunotherapies use the power of your immune system to fight cancer. and they're pretty good at fighting liver cancer. The key to treating liver cancer, just like any other cancer, is catching it early. And that's why we're talking about screening and hepatitis B and all those kinds of things. Because if we do catch it early when it's small, the treatment options are pretty broad. Another treatment option that I didn't mention yet is something called TARE or TACE, or we may call it Y90 or local regional therapies. Those all refer to vein-based therapies. So you put a catheter in the neck or in the groin, run it up into the liver, and then you just drop beads in there, or you put radiation in there, or you ablate that area with microwaves. You give a very focused area of the liver some degree of chemotherapy or radiation so that you minimize the side effects throughout the body, and it just focuses on that area of the liver. And those are good options too. But again, as you stated, Dr. Thomas, it really depends on the health of the patient, whether or not they have cirrhosis, and the extent of the cancer.
Okay, so related to treatment, there's a question asking about in a patient with hepatitis B that gets a transplant for liver cancer, can that cure the HCC and the hepatitis B, or will it only cure the liver cancer?
99% of the time, only the liver cancer. There's always a risk of patients who get transplanted, regardless of the reason for the transplant, who have had hepatitis B, that hepatitis B will reactivate. And that is because transplant patients are on immunosuppression for the rest of their life to keep them from rejecting that organ. Regardless of what organ you get, you need immunosuppression. So a patient who gets a transplant for liver cancer and hepatitis B is curative for the liver cancer, but the hepatitis B will continue to need to be treated for the rest of their lives. Now, just one caveat to that, there is a risk of recurrence of liver cancer after transplant. In fact, the recurrence rate now, depending on where you look with our current therapies, is about 12%. So some patients will have recurrence of liver cancer, but the survival is still better than those patients who weren't transplanted.
Fantastic. Here's another question related to fatty liver, specifically on when should a patient really go to get a biopsy. And the specific question is, my friend has fatty liver, S2 and F0, and she is concerned that it will progress. She wants to know if she should ask for a biopsy now.
Oh, that's a good question. In general, fatty liver, you can divide it into two categories. Really, you could divide it into more, but for the purpose of this question, two categories. Patients who have what we call MASLD, or fatty liver disease, and people who have what we call MASH, or previously called NASH, or have this steatohepatitis, that's what the SH stands for, or this inflammation. Those patients probably need a biopsy. And the way you would know whether or not you had one or the other is usually the liver tests. So if the transaminases, if the liver numbers are elevated, or if the patient shows signs of decompensated liver disease that we mentioned before, jaundice, swelling of the abdomen, or confusion or varices or things like that, then those patients might benefit from a biopsy. Not everyone with MASH needs a biopsy, but it does help us determine a couple of things. One, it does give us a very accurate determination of the level of fibrosis. But two, a lot of patients with MASH need to have underlying liver disease ruled out. Not all of them, but many. I don't know how deep into this get into this, and as far as we are in the presentation, but in general, MASLD or fatty liver disease is very prevalent. We think about 30% of Americans may have fatty liver disease. That's a lot. It probably has to do with our diet and our lifestyle. Most of those patients will never get MASH. Most of those patients will never get cirrhosis. And so patients who do develop MASH or do develop those abnormal liver enzymes, they may merit a biopsy because there may be some other reason that they're getting these abnormal liver numbers. In general, people who have S2 with F0 fibrosis don't need a liver biopsy. They just need monitoring of their liver function. And they may need to follow that with a FibroScan or some other liver test to follow the degree of fibrosis. The treatment for fatty liver disease is diet, exercise, weight loss, all the things your doctor would tell you to do anyway.
Fantastic. Okay, thank you for that clarification. Beatrice, so we're going to wrap up here. We did put in the chat the details for the hepatitis B virtual liver cancer patient event. Beatrice, any final words on that event, and anything else from the Hep B Foundation for our viewers?
Yeah, we would just encourage everyone to come to the conference if you can. We really hope to try to paint a holistic picture of liver cancer from the perspective of researchers and providers, people with lived experience, and people who work in the community. So we hope that it will be a good and comprehensive event. And it is it's focused on a lay audience, so it won't be overly technical. We do with the agenda. There you can see all the different sessions. So it is a long event. It's 3 hours. If you can't make the entire thing, you can feel free to just register and come for the sessions that are of interest to you. So yeah, would encourage you to check it out, and feel free to reach out if you have any questions about it. Thank you.
All right. I'm going to turn it back over to you, Ivory. Thanks, Dr. McCain. Thanks, Beatrice, for your contributions. ALF sincerely appreciates your help with this.
Thank you.
Thank you so much, Dr. Thomas. Oh my gosh, that was such an informative program. I am so excited. We had questions just coming in left and right. As Dr. Thomas said, thank you so much to Dr. McCain and Beatrice for such an informative and engaging presentation. We're looking forward to posting this on our social media channels and our YouTube channel. If everyone has any more questions about liver disease, the American Liver Foundation is here to help. Call our helpline at 1-800-GO-LIVER or visit liverfoundation.org to view our robust library of educational resources and support services for patients and caregivers. Again, we will provide all attendees with resources and links for more information that was shared today in the follow-up email, as well as on our Facebook page. Thank you all so much. Have a good day.